Good morning, everyone, and welcome to this knowledge exchange workshop between the Basque Country and Slovenia. My name is Andrea Pavlikova, and I'm International Engagement Manager with Scottish Government, and I have a pleasure to coordinate Scirocco Exchange project and also host today's knowledge exchange workshop. As you know, this workshop or this session is organized within the framework of Scirocco Exchange project, which focuses mainly on the support to health and social care authorities in their efforts to improve the implementation of integrated care. And for us, really, the main driving force in the project is that we promote or facilitate knowledge transfer and exchange of good practices between the partners so that we don't reinvent the wheel, but really learn from the existing evidence, existing good practices, knowledge and expertise, which is on the ground. So even for the purpose of today, we have identified the topic of health and social care coordination in the Basque Country as one which has been of interest to our colleagues from Slovenia. So the objective today is to learn and share the experience of the Basque Country in health and social care management in integrated care. And particularly we'll be also looking at one stream which is around the mental health and management of the addictions and how the mental health services are integrated in the wider health and social care services in the Basque Country. So as you could see from the agenda, in the morning, we will focus primarily on the topics of health and social care management. And then after a short coffee break, we will look at the aspect of mental health. And then we will also hear from our colleagues from Slovenia about their healthcare system strengths and weaknesses in integrated care. Before I hand over to Jon to introduce the colleagues from the Basque Country, I just would like to remind ourselves a couple of housekeeping rules. So as it was kindly introduced by Aleš and Jon, we have two simultaneous translation today. So you can choose your channel in which you want to listen to. I would also kindly remind speakers that because of these translations, it would be great if you can speak slowly because there might be some delay in the translations. Also, for those of you who don't speak, please mute your microphone. And the last aspect, as you can see from the agenda, we will have a dedicated discussion, but I would also like to encourage you using chat as we go through the presentation, so that we don't forget any of your, questions, remarks, or observations. So please feel free to use this functionality as we move on through the workshop. So without further ado, I'll hand over to Jon to introduce the team from the Basque Country, and then we will, as I was saying, we'll start with the focus on the health and social care management aspect. Jon?
Buenos días, Andrea. Muchas gracias. Well, good morning, Andrea. Thank you. Thank you very much. If you agree, I'm going to be sharing the agenda with you so that we can all see what we're going to be doing this morning, right? Let me try and share my screen now. Can you see it? Good. Let me start by thanking Andrea and the Basque and Slovenian teams for being here today. We're going to be starting this morning session with José Antonio de la Riga, Director of Social and Healthcare of the Basque government. Is going to be giving us some context, social context in this case, and the healthcare context in Basque Country. And then he himself, together with Amaya Sáenz de Ormijana, who is social health coordinator of the territory of Álava, will be talking to us, together with Lucia Íñigo Basque from the Basque Foundation for Health, Innovation and Research. They will be giving a presentation, and then after the coffee break we will be hearing from José Antonio de la Rica. He'll be talking in that case about mental health. And then later on we'll be hearing from the Slovenian team who will be giving us information about the strong points and weak points they have detected using the Scirocco tool. But I believe it's best for them to introduce themselves. So Andrea, I'm going to be handing them the floor, if you agree. And of course, I'll be ready to help anytime at a technical level. You can write to me on the chat, right? Thank you very much. Well, let me start. My name is José Antonio de la Rica. As Jon said, I am the Director of the Social and Healthcare of the Ministry of Health of the Basque government. At this department, we've already been working on social and healthcare for 25 years. In the past 10 years, we have consolidated our strategies, and I'm here as a representative of my team. And Amaya and Lucia, you can now have the floor and introduce yourselves. Well, good morning to you all. My name is Amaya Sáenz de Ormijana. I'm a nurse, and right now I work as a liaison or as a social and healthcare reference of the integrated healthcare organization I work for, which is the organization that provides healthcare services to the province that is located at the south of the Basque Country, which is Álava, and I'm going to be sharing with you my experience. Thank you.
Lucia, ¿nos escuchas? Creo que es tu turno.
Lucia, can you hear us? I believe it's your turn to open the mic. José Antonio, it seems that Lucia cannot hear us. Well, I believe she's not connected anymore. I can't see her. I believe she's lost her connection. She'll be right back. She was here a minute ago, but she's not there anymore. Right then, well, we can start, and then Lucia can introduce herself, right? Is that all right with you? Fine, yes, of course. If you're all ready, I'm going to be sharing my presentation. I'll be sharing my screen now. Yes, my mic's on. Everyone can hear me. Okay, let me first of all say that it's a pleasure for me to be here with the Slovenian colleagues. I hope that what we're going to be telling you this morning will be interesting to you. I don't know if John has distributed this presentation, but of course it will be available to you, of course, anytime. So I've included a couple of additional slides in my presentation because I've realized I hadn't included any context about the Basque Country, about the autonomous community of the Basque Country. And I believe this context is necessary for you to understand the political framework in the Basque Country and also the demography and our geographical framework as well, in order for you to better understand then all about our health service. You see that the Basque Autonomous Community is geographically quite small but highly populated. We have a relatively small territory, and we have three territories, three provinces that are quite small, the smallest in the Spanish state. And nevertheless, as you can see here, up on the screen, you have an estimate of the number of inhabitants we have, which is about 2 million inhabitants in the whole of the Basque Autonomous Community. And you see that there is an uneven distribution in the three different territories. Álava is the least populated territory, which is in the south. And then the coastal territories are more populated, as you can see there. So, and well, you see here in this slide, the political system we have in the Basque Country. This political system is very characteristic in the Spanish state. We have a statute of autonomy, like all Spanish autonomous communities, and this statute is the one that rules through the Basque government and is represented by the Basque government. Then the second level of this structure is the law of historical territories. The Basque country has a very wealthy history with a number of different conflicts that went on in the past. And this has shaped our territory. We have this, therefore, this historical territories law, which rules over our territory and controls the different powers concerning health, education, justice, etc. They are in the hands of the Basque government, but there are other powers, like, for instance, in powers that have to do with the treasury, with social services. Those are in the hands of the different territories in the Basque country, and they are managed by the provincial governments. I will tell you more about that later on. So we've got a very confederal country with high autonomy in the different territories. We also have a situation of respect and equality among the different territories, and this has led to some historical inequalities which are still present in the Basque country. And in order to complete all this structure, I would like to mention the different city councils and municipalities and the different municipal bodies. They don't have a hierarchical organization. I mean, we don't have different levels, one above the other, but rather a situation of autonomy in terms of powers. And this makes our environment especially complex from both the institutional viewpoint and the micro level when it comes to making decisions concerning care. Fine. Well, having said that, and after this short introduction to provide you with some context, you will see at the bottom of all the slides, we're going to be having some logos corresponding to the Basque government, the three different provincial governments, and EUDEL, which is the Association of Basque Municipalities. I've included the logos because the social health strategy at the end of the day is a consensus or a way of gathering all those institutions in the Basque Council of Social and Health Care. And that Basque Council is the one that shapes the strategy that will be applied in the Basque country. And I will be mentioning that later on as well. The Basque Country Social and Healthcare Strategy, therefore, is a shared project among the institutions and is guided by a common objective, which is meeting people's needs. Of course, it couldn't be otherwise. This strategy has been developed, as I imagine, in Slovenia and also in Western countries. It's been developed in a context marked by deep social and demographic transformation, but also structural and systemic. We need to take into consideration here the aging of the population, and of course, we cannot forget the COVID-19 pandemic. This demographic context is very systemic and is shaped by the aging of the population that of course is progressive and has a positive side to it because it has increased the life expectancy of our population. This is one of the reasons why people age, but there is also a negative impact of aging because we have a lower birth rate, which in the Basque country is extremely low. And then the aging of the population also has a series of elements or factors that need to be mentioned, like the increase of the number of people that are in situation of dependency or that are not 100% functional or that have disabilities. Let me give you some organizational context in order to solve all these issues that we have in our reality. As I already said, we have a number of different services that are provided by the Basque government in the whole of the Basque autonomous community. And those services are basically provided by the Department of Health and Osakidetza, which is the Basque Health Care Service. It is a public service that is universal and that is, I would say, the most important one in the Basque Country. And I would also say that we have here the Department of Equality, Justice and Social Policies that implement a number of different services, but mainly strategic ones, like, for instance, tele-assistance, telecare. And then we have in the Basque Country 3 provincial governments, one in each territory, and they provide social services, specialized social services concerning minors, inclusion, disabilities, etc. And then the basic social services are also provided by these provincial governments that would be related to situations of social emergency and are also a way to access the specialized social services. As you see, this is quite a complex situation, the one we have in the Basque Country. So in order to understand all this system, all this complex and fragmented system, we have a law on social services. Its Article 46 defines social health care, which comprises all care for persons who, because of serious health problems or functional limitations or risk of social exclusion, require simultaneous, coordinated, and stable health and social care in accordance with the principle of continuity of care. So this is the way we define our services. Jose Antonio, excuse me, could you speak slower for interpreters? Yes, of course. I'll try to slow down. Well, this is our coordination space. We can see here up on the slide. We don't have a social health space as such, a third space where we overlap social and health services, but social health care is a space for people that have social and health needs, where both systems collaborate, the healthcare service and the social services sector, in order to meet the needs of these people. So, to whom are we addressing social and health care? According to the law, it is aimed at different groups of people that you can see here. These are the main ones: people with disabilities, people in a situation of dependency, people that lack protection. It could be aged people for a number of reasons concerning abuse, maybe children as well, and teenagers, minors, generally speaking, also women in a situation of gender-based violence, people that have mental health problems, people with addictions, drug addictions, end-of-life situations. As you see, there are many, many people included here. We have reduced our target groups in a specific way in our strategy to focus better all our services. So we've got these specific target groups: people with disabilities or dependency, people with severe mental disorders, people at risk of exclusion and lack of protection, as we said, especially victims of abuse, children with special needs, especially children that require early care, and other groups with social and health needs, like people in situation of end of life, gender-based violence, etc. This is a complex institutional framework in which the consensus among the different stakeholders from the different areas and levels of care is essential in order to provide coordinated social and healthcare. So we've all tried to do our best here in this very complex framework to develop our negotiation skills in order to come to a consensus and generate common spaces and a common ground so that we can work together. And this, I believe, is one of the strong points of the Basque system. What are the key factors here? The driving factors of our model. Well, on the one hand, I would say we have accessibility. The place of residence is the place where people get social and healthcare. This is different from care that is provided in health centers, hospitals, etc. So there is a difference here. Care is provided at home, so it is more accessible. So we have decided that that is the best way to provide social and healthcare. Another key factor would be the results, the outcomes we get. We want to have an impact on the health, autonomy, and the quality of life of our patients. That is our main goal. Another key factor would be our focus. We are person-centered. We place individual at the core of our system. And another key factor would be our care models and this care continuum, which is the way we see care. This is what you see here. We need to understand very well all the elements of the life of a patient. In some cases, we need early interventions that can lead to possible or potential situations of disability in the future. And we need to understand this social and healthcare system as a continuum. We try to move from a system based on cooperation, which was between different cooperation between different. That's what we used to have so far. In the past, each system would have their own plan, both concerning health and social issues. And then we talked between the different systems. And now we have a peer-to-peer coordination-based system, and we have a single plan for all of us, which is an individualized plan. I am moving on to a situation of functional integration. So this is very deeply rooted in the Basque political structure. Our idea is that citizens don't really need to know whether in order to meet their needs, the service is managed by social services or by healthcare services. Citizens should only be worried about the fact that their issues are duly managed and taken care of. Here we see the longitudinal perspective of care, which is this continuum I just mentioned. We've got a number of different levels there. It is also important to reach a coordination and balance between the different levels. That's what you see here. We need to coordinate the levels so that the care provided at a micro level is efficient enough. And this is why we have this macro level represented by the logos you see at the bottom of the slide, i.e. all the structures. This is the political level, the strategic level that needs to enable the other levels by means of rules, regulations, decrees, budgets, etc. The idea is that all the needs existing at the micro level can be met. There's also a middle level, which is the level where we will find all the organizations that provide services. So these service providers need to distribute formal and functional resources. And then we have the micro level, which is the most important one, I believe, because that's where care is provided. That's where we see the actual reality, and that's where we have the practitioners that provide services, and both in concerning social and healthcare. And we also have citizens. So we need to strike a balance between all three levels. We need a macro level that understands politically that this is a relevant area for citizens. If this is not the case, probably the other two levels won't be doing that well. And on the other hand, if we don't have a level where we have practitioners that are aware that care should be individualized, well, then care will not work properly. So within this context of ours, we have a number of areas of action. I believe they're very interesting, but unfortunately, I don't think we'll be having time today to go deep into all of them. So here we have, first of all, the development of a social health governance model. Secondly, the promotion of social health interoperability. Third, the design of social and health prevention frameworks. Four, the deployment of social and healthcare. And five, the promotion of social health, R&D and I. So everything that is related to social services and health services need to be able to share information in order to work more efficiently. I've also mentioned in the fifth point, R&D and I. Well, I believe that we are getting knowledge in our processes and we need to make the most of it. Now I will move on to the second part of my presentation. I don't know how well or bad I'm doing for time. It's fine, John. You can go on. Fine, thank you. So as I was saying, this is the second part of my presentation. I will resume my presentation. If I'm speaking too fast or there's something that's not well understood, of course, there will be time for questions later on. Don't speak fast, but keep it short, because if you speak too fast, they won't be able to follow you, right? And the interpreting service will not be working properly, right? So you shouldn't speak faster to make the most of the short time you've got left. Okay, let me mention the social and healthcare management. I'm going to be mentioning here our governance model in our institutional context. I've already told you a few things about our model so far. It is a very complex context, as you have seen, and for our governance model, we first of all need to define the social and healthcare governance. And for that, we have a technical working group that takes into consideration all social services. So this is a system of systems. As I said, we've got the 3 provincial governments that provide a specialized social services. They have a multi-level governance. And there's also a different political development and administrative development in the different territories. In each territory, so in each provincial government, the political representative could not belong to the same political party that is ruling in the Basque government, in the Basque administration. And if you include the different municipalities in this equation, then you will see that we've got many different political colors and political representatives, which will lead to a more complex situation in terms of service and the services we're going to be providing. This leads to a risk of territorial inequalities. Some territories have some services that are not available in other territories. That is something that could happen. We also have different access conditions. So we need to govern all this somehow. We have the law on social services that mentions the complexity of our situation and states that equity should be important. Opposed to this, we have the Basque healthcare system, that is one single system that reports to the Basque government. So this is one single system, as I say.
Oblikovanja modela za upravljanje sociale in zdravstva. Gre za enoten
I'm very sorry, but I can hear someone speak Slovenian in my English channel. Okay, it's fine now. So it is the largest healthcare service provider in the Basque government. I'm very sorry, but again, I can hear someone speaking Slovenian in my English channel. Thank you. So equity, territorial equity needs to be guaranteed in all social services. In our Basque health system, this equity is guaranteed since we have only one single system, right? We had this need to define a social and healthcare governance model that takes into consideration all the situations in order to alleviate the absence of existing regulations, because the existing regulations was basically the decree that was quite general. And then secondly, we needed to have an orderly participation and relationship with all the levels. So the articulation of social and health governance model is based on a number of different features that you see here. We have 2 areas of public policy management that cover social services and health. We also have here 3 levels, the macro level, that's political and institutional, the middle level, and the micro level that provides direct care. All of them are very important. And finally, we also have 2 dimensions, the organic and the functional dimension. As I've already said, the social and healthcare space is not a differentiated space, but rather a space of coordination of the different systems. So all this with the objective of having a functional integration, and that functional integration needs to be based on a number of different relationships, structures, functions, and tools. So we need to handle the same information in both systems. We need to have the same or similar tools to develop unique individual plans for the citizens. And although these structures have different responsibilities, they need to work on the same criteria so that citizens can go to the different institutions and get a unified information.
Now, how do we articulate this model? Well, to continue on from what we've been mentioning so far, it's based on respect for the autonomy of the different competent institutions. It's also based on co-responsibility. It also acts under the principle of consensus. And also there needs to be a harmonization of actions in the search for effectiveness and efficiency. Because otherwise, in a system with so many different stakeholders, it's very easy for redundancies to emerge, to have a duplication of resources, and this is what we want to avoid. So we're always searching for effectiveness, for efficiency, and we do this through harmonization, and that's very important. And then also there's a promotion of continuity of care and also providing coordinated care. And what we have here, let me see if I can find it. Oh, sorry. I thought there was another slide in between these two. It seems to have disappeared. I don't know what happened to it. I'm sorry about that. But based on all of this, we have compiled a catalogue of social and sanitary and health resources. This catalogue aims to set out very clearly what are the resources to which citizens will have access. So there's a series of instrumental resources. Instrumental resources, first of all, are those which enables us to cover the social and healthcare needs of citizens. It will also enable interoperability. In other words, it enables information to flow in both directions. It also includes primary healthcare and primary social care. So the teams, in other words, the social teams that work at different local councils or provincial councils, the physicians who work in primary care, and these instrumental resources aim to make sure that all of this is coordinated and that there's a coordination in the primary health and social care. And there's also an educational element to this, because we also talk about education for, especially for children with special needs. And the assessment is also important. The assessment needs to be carried out jointly, and it also needs to be carried out in relation to a central element in all of this, which is the creation of personalized care plans, which, as I said before, needs to be the same care plan for both systems. So there's a single plan. And you can only have a single plan for both health care and social care if there is good dialogue between the two systems, if there is proper coordination between the stakeholders who work in both systems. This is very important to have the single personalized care plan. And then we also aim to provide coordinated access to co-financed resources. So if somebody needs access to specialist resources, these resources are included in the catalogue, and therefore access to those resources is coordinated as well. To continue with the different resources that we have identified as social and health resources in this catalogue that I've just mentioned, there are different types of resources. We've talked about the instrumental ones. Now we're going to have a look at the ones that we call finalist resources. What are they exactly? Well, they're a set of services and benefits which are contemplated by the respective social services and the health systems. So they're quite versatile, and which, when they're simultaneously or sequentially applied in a coordinated and a stable manner, will be able to respond to any situation that may occur when someone goes and accesses these systems. If there's a social situation, for example, it might have to do with a health issue, it might have to do with a disability, it might have to do with exclusion. So we need to make sure, as well as having multi-purpose socio-sanitary residential units, we also have a number of different resources as well. For example, residential centres or care homes for the elderly, residential centres or care homes for people with disabilities. The same for people with chronic mental illness, daycare centres for people with chronic mental illness, and the telecare services, which is public. These are all the services which have been around for a long time now. They're well consolidated, but they need obviously funding, but they also need a collaboration between the two systems, the healthcare system and the social system, in order to provide the best possible care. And then there's another type of resource that we have identified, which are finalist resources, but they aren't quite so focused on the health field. They're more focused on the social field. So these are basically all the different resources. I wouldn't say they were second level as such, because they're very important and they do provide a response to certain needs, but I would say that they were, how shall I put it? They're not as present in most people's lives as the finalist resources that I mentioned in the previous slide. So this brings me to the end of my presentation. I'm going to pass the floor now to Lucia and Amaya, and they can talk about the different figures that we have identified, the different categories or the different professions that are involved in the coordination between the social and health services within this extremely complex coordination system. And they're going to tell us a little bit about what the key elements are. They're going to talk about financing and the budget, etc. So, Lucia, the floor is yours. Hello, everyone. Thank you very much. First of all, I would like to apologize because I lost my connection when I was going to introduce myself. So I'll introduce myself now. My name is Lucia Íñigo. I work at the Basque Foundation for Health, Innovation and Research, also called BOF. Now, I'm going to talk about the model, the social and health model, but within that model, I'm going to talk about the structure. I'm going to talk about the macro, meso, and micro organizational structures. Now, you can see on the screen a diagram And I'm going to be focusing on the right-hand side where it says figuras de coordinación, coordination figures. So who are we talking about? So I'm going to explain who we're talking about when we're talking about the different coordinators, sort of put faces to names. With the decision-making bodies, this is on the left-hand side. This is more about commissions and institutions. And this, on the right-hand side, we see the figures, and this is what really affects professionals. And on the right-hand side, there are three different areas. In the micro and the meso levels, we have the social and health reference or reference figures. And then a little bit further up, we have territorial or provincial social and health coordination. And then there's a higher level, which is for the entire autonomous community of the Basque Country. And this is what José Antonio represents. But we're going to be talking about the two lower levels now. So what you can see here, it really pertains to the other block, but we wanted to talk about it here just for a moment, because I think it reflects the way we work at the micro level. So basically, we have coordination teams or social and healthcare coordination teams, and they are professionals who coordinate in order to provide simultaneous coordinated care to the different needs that one person may have. They are the first port of call for someone who requires some kind of attention or care, and they are multidisciplinary teams. So there are professionals who come from maybe social services, municipal services at a local level, and also social services at a provincial level as well. And then that's for the social side of things. And then on the healthcare side of things, we have physicians, nursing staff, and other people who work in the healthcare field. And all of these figures coordinate in order to provide a response to a patient's needs. They're not structural teams. They're not the same team in each institution or each center. They're just people from different institutions who work ad hoc. So they act when they're needed and where they're needed, and they coordinate when and where they're needed in order to provide the response required in each moment. Now, when we talk about these teams, we always highlight the fact that they're not structural teams and they don't involve the creation of new jobs or hiring new professionals. No, there are professionals who are already in the system, but they just include in their everyday work another task, which is to coordinate with other areas outside their immediate field. These teams, it's all based on case management methodology. So it's based on the fact that information is shared between these different professionals. Now, let's talk about the next figure at the micro level, which is reflected in the governance model. And these are what we call social health or social sanitary, as it says on the screen, reference or reference figures. Now, these are reference figures in each organization who, due to their experience or their expertise, are key figures for guaranteeing good coordination of the different cases so that there aren't, I don't know, information vacuums, for example. There aren't questions asked with no feedback received. They're responsible for ensuring the good quality of the coordination between the health and social systems. So these socio-sanitary reference or social health reference figures form part of the social and healthcare governance model, and they have a number of different functions. The first one is to function as an intermediary, as a liaison, if you like, between the care level and the organization. So between the different levels of care at which they work and then the different levels of care with which coordination is required. So they work as a liaison. So these reference figures, these are reference figures that we've been working on and trying to develop for a long time now, since about 2015, especially in the healthcare field. They're figures, these reference figures, that were established as a result of a pilot project that we carried out around a measurement instrument or an assessment instrument. And we've created this figure of reference figures, coordination reference figures, as a sort of the visible face of the more extended use of this assessment instrument. So in the healthcare field, this idea of the figure was fairly consolidated, but they needed to be set up and developed in the social side of things. And as José Antonio said, it's a complex system. It's very fragmented. There are many different levels of care. They have local health social services, and then there's another one which is territorial or provincial level social services, and they all work in a different way, and sometimes coordination is problematic. So developing this figure of a reference figure was very difficult. It is still difficult. We're still working on it, but we do now have reference figures in all the different organizations, all the different integrated healthcare organizations, in all the different mental health networks. We have one in each of the historical territories or the 3 provinces of the Basque Country. We also have reference figures in the different associations of municipalities and town councils, and they provide basic social services. And we also have reference figures at all 3 provincial councils of the 3 historical territories or the 3 provinces. Historical territories is what we call them in the Basque Country. And the idea is to improve the coordination of the care we provide citizens. Currently, there are more than 70 professionals who have been identified as reference figures in the different organizations, and the aim is to increase this number over the coming years. So I just I think I'll just pass over to Amaya now. But before I do, let me just say that the reference figures, this whole idea of reference figures is being developed and deployed at the moment. We have more than 70 at the moment, but the aim is to have reference figures all over the Basque Country. I have many more things that I could explain to you, but I don't have time. So I'm going to pass the floor to Amaya. And if you have any doubts, or would you like to ask me any questions, then please do so during the Q&A. Amaya? Good morning, everyone. Hello again. Amaya? There seems to be some trouble with Amaya's sound. I can hear you okay. Sorry, well, I'll start again. Good morning, everyone. Now, I've just got a very short presentation. I'm just going to talk about the meso level, which is the level between the micro level, which is everyday work with cases and people, and the macro level, which José Antonio represents, which is more a decision-making level and a structural level at a provincial level. But I'm going to be talking about the different decision-making organizations and the working plans with which we carry out social and health care services in each of the 3 provinces of the Basque Country, so at a territorial level. This is what we call the territorial councils. You could also call them the provincial councils. So they are there in order to assess and audit the social and health coordination activities and the plans that we're going to be talking about in a moment. So we assess the plans, and then we assess the different needs, and then it also says what we should be doing the following year. So it assesses the plans in the past and gives ideas about what needs to be developed in the future. It's a technical and political council. So on the council, some of the members are more technical in their profile. But of course, we also have the political side of things represented there, because it's the politics and the politicians that will decide how to fund and what plans to fund and what activities to fund. So both are represented on the council. The council meets once a year, usually towards the end of the year. And during that meeting, we have a report on what has been done in each particular area. And then we also define what is going to be done in the following year. As I said before, the councils meet once a year, although the plans, the territorial or provincial plans, are 2-year plans, because things don't change quite so quickly. Obviously, in the micro level, things change quicker because the decisions need to be made more quickly. Sometimes you just meet up and decide something in a single afternoon. But at the higher levels, decisions happen more slowly and they last longer. So who sits on this territorial council or provincial council? Well, we have representatives from both the healthcare side and the social side, and people from the meso and macro levels. In my specific case, I represent the micro level as well, because as well as being the coordinator for the province of Álava, which is one of the 3 provinces in the healthcare side, I'm also the health and social coordinator and representative for my particular organization, which focuses on complex cases. So I'm there representing that organization as well. So I do represent the micro level, but usually it's only the meso and the macro levels that are represented on the councils. So on the social side of things, in the province of Álava, at least, we have the town council of the capital city, Vitoria-Gasteiz. The capital city actually accounts for a large part of the population of the entire province. So most of the population lives in the capital city, in the province of Álava. And the social services, we also have the provincial council, or the provincial government, they sometimes call it, and their social services department, which is the service provider, the main service provider in Álava, in the province of Álava. Although, if, for example, in the smaller villages, not that are outside the capital city, it's the provincial council or the provincial government that provides social services. And then on the healthcare side of things, we have the mental health networks. And we also have the organization which provides normal healthcare services, which is where I work at a micro level. And they are called integrated healthcare organizations, IHOs, and there's one in each province. So in the territorial council, we have these 5 organizations represented. And then also on the healthcare side of things, we also actually have the Basque government provincial delegation for health affairs. This is what José Antonio was talking about earlier. The health department is responsible for making sure that there is health service throughout the entire Basque country. So they have provincial delegates. So they have delegations, for example, in each of the 3 provinces. So we have the Basque government at the top, and then in each of the provinces, there's a Basque government delegation for health affairs. And that provincial delegation also sits on the council, because many of the agreements that are signed are not signed directly with Osakidetza, the public healthcare system, this healthcare provider. They're signed with the body which is responsible for guaranteeing these services, which is the Basque government, the Basque regional government. So why it's really important that they're there, because they're the ones who are going to be paying for everything. So can we see the next slide, and we'll see what the councils actually do and what they focus on. So they work on the territorial operational plans. So these are the operational plans.
Las 2 coordinadoras territoriales, tanto la coordinadora de Álava en el ámbito de lo social como la coordinadora de Álava en el ámbito de la salud, que sería yo, desarrollamos
Most of the time. So they describe their goal is to describe the plans, programs, and activities which have to do with the social and health coordination needs and challenges. So we have the top level, which is represented by José Antonio, and it's at that top level that they define the priorities. But then based on that, we operationalize, if you like, these priorities and make them tangible. So we take these high level, more abstract priorities and bring them down to the level of each of the provinces to see what the actual structure is going to be. How does all this translate into actual healthcare services and social services that needs to be provided to the citizens of the province, in this case of Álava, for example, but the same for Vizcaya and Gipuzkoa. So it's a technical document, but it is reflective of a political commitment, because otherwise there's no point, right? I mean, we can work as much as we like, but if we don't have a political commitment behind us, then we're not going to be able to do very much at all. We need that political support. So the development is technical, but it is backed up by a political commitment. The plan is developed once every 2 years. So we have a new one. I think at the we were supposed to have a new plan at the end of 2020, but then of course COVID happened, and we all know what that meant. So we need to start developing the new plan now. Can we move to the next slide now? I'm not going to go into too much detail into the ins and outs of the operational plan because it would take too long, but it's based on 6 priorities, the 6 priorities that were identified at a macro level. And just to give you an example of how we actually develop these priorities, let me give you an example of some of the specific plans, the specific activities that we are going to go. José Antonio, could you please pass to the next slide so we can see what I'm talking about? Once we've done that, you can see it, but you need to be able to see it. Probably it's going to help because they're very specific plans in many areas. And in fact, in some areas, because of COVID, we've had to actually move forward much quicker. And on the basis of trial and error, because we haven't had time to pilot different initiatives that have been made necessary by the COVID pandemic. So trial and error with many errors. We've had to ask for forgiveness many, many times. But here we can see an example of how the high-level priorities are translated into operational plans. We had a coordination protocol up until recently, in which we had the provincial council and the local councils, etc. But that didn't seem to make much sense when we realized when we're talking about integrated healthcare, because the person doesn't know whether they should go to the local council or to the provincial council. If they have a need, they just need to go to their nearest service provider, which is why we had different protocols, and now we have merged all of those protocols into a single protocol. And so no matter where someone goes within the primary care service, the protocol is the same and they all get channeled through the same system. We have the same communication channels. We know who they have to be referred to, for example, who my reference figure will be in my particular area, what we have to do in order to respect confidentiality according to the data protection law that we have in Spain, which obliges us to only share data in a certain way. It also sets out what is urgent, what isn't, what can be programmed, what require greater planning, i.e. something that's not just a quick response to this particular case, but it's a more complex case, or it's a case that happens many, many times. There are many examples of it, so it requires greater planning. All of this is reflected in the coordination protocol. They're updated, these protocols, very often. Another specific project that we have, which is at a macro level, but it's actually operationalized at the micro level, is the implementation of the electronic health records in nursing homes. Now, this is a macro project because it covers the entire Basque country, but it's developed at the micro level because different nursing homes become, as they develop, they become candidates for having the electronic health records. Not all nursing homes comply with the conditions because they need certain requirements, certain conditions. So as they fulfill these conditions, then they get absorbed into the electronic health record system. So some nursing homes, but gradually they are being incorporated into the electronic health records. And in fact, because of the change in the legislation, more and more nursing homes are becoming candidates. So it's an ongoing program because we receive requests and applications constantly for nursing homes to become part of the electronic health records system. Another development that has to do with the macro level, but is developed at a micro level, is the social and health electronic records, which the electronic records which combines both systems. Another project which is more at a meso level, which is being developed at a provincial level, is the development of what we call coordinated care pathways. Specifically for complex cases, for very targeted populations. And here, of course, we're talking about populations or people that need some kind of planned healthcare. So they need these groups, for whatever reason, they need a much more specific plan for everything that they do. And we need to guarantee that all of this is guaranteed is developed in the same way.
Muchas de estas poblaciones son poblaciones asociadas al ámbito de la salud mental.
Many of these populations have to do with mental health. It's older people, children, people with disabilities, etc. So as you are experts in mental health, you may well know that mental health conditions, any type of intervention from the social and health care services. So we need to put on some different glasses in those cases. So the professionals working in the management of these profiles need to be able to put on these glasses easily, or once they've got them on, because many of you have the necessary training and experience to have those glasses on. So you don't start from scratch with every new case or every new patient. And then finally, here in the territory of Álava, our reality in nursing homes is slightly specific. There are 98 of them. Many of them are very small. They don't have their own healthcare teams, which requires a very close relationship with primary care. And this is where we have spotted some areas for improvement and where we have established a line of work that is very specific to our territory, because it was obvious we needed to concentrate on that. So we're working coordination to provide treatments that have to do with blood thinners or anticoagulants, and we try and provide care to patients in primary care centers, also always respecting the privacy of the patients. Another element was the provision of healthcare material for a number of different tasks. that needed to be carried out on patients. We needed to regulate all that because it wasn't very well organized. How would patients require those services and what type of material we need to give to each nursing home, etc. So we've tried to regulate all this, but of course, due to COVID, and I guess it was the same case in Slovenia, well, things were more complex. Many COVID tests needed to be run. The vaccination campaign needed to be organized. And we, in this case, needed to focus on the elderly, older people that were the ones that got the vaccine first. Well, and that's more or less the work we carry out daily, and that is translated at the micro level. But I try to explain this meso level where we work, both coordinators, Esther in the social care and myself in the healthcare field. Thank you very much. And I'm now very happy to take your questions, of course, now or maybe later, and I can give you my email address so you can contact me directly. I'll be very happy to learn with you. Well, thank you. Thank you very much. This has been teamwork. I haven't been able to listen to you. Lucia was telling me when I needed to change slides. Well, Jose Antonio, I haven't been able to listen to you earlier either. So, well, in order to finish with this first part of the session, let me tackle something that's very interesting, because in all management manuals it is said that, of course, intentions and policies need to be reflected in the budget. So funding is a core and a key element in our institutional reality. And of course, all this has a clear reflection on the service we provide to citizens. So everything that has to do with the social and healthcare field needs funding. And here, there's something we need to take into consideration. There are two types of portfolios. One would be healthcare services, and this portfolio covers for all the healthcare systems in the different autonomous communities in Spain. And then we have a portfolio of social services that is specific to the Basque Country. As we've already said, sometimes there is this confluence of needs that are shared in both systems, and therefore, in order to guarantee continuous care, we need both systems to converge and work together. So sometimes we need to these elements to be included in the funding service. In the Basque Country, we've got three types of funding. On the one hand, we've got resources coming from the social services, but which are co-funded by the institutions in each territory and also the Basque Department of Health. In this case, concerning co-funded resources, we find for instance, homes for people having severe mental disorders, and also social and healthcare service units. Secondly, we have territorial funding resources. In this case, we would include nursing homes and homes for people with disabilities that internally have healthcare staff like physicians, nurses that belong to the territorial system, to the social service system. And therefore, these resources are co-funded by the healthcare service. And finally, and thirdly, we've got resources that don't have any shared funding. These resources respond to social and healthcare needs that exist on a daily basis, and that funding will depend on the healthcare system or the social care system. Some examples of these resources would be, for instance, in all the nursing homes, we've got the electronic health records that are available for the healthcare staff working in nursing homes, although they're not part of the healthcare system, and all this is funded by the healthcare system itself. We also have here psychiatric hospitals where we could have people that can be discharged but cannot leave because there aren't any social resources available in their territory. So in this case, we have this type of funding. We have a healthcare resource that's working as a social and healthcare resource. And then there could be other examples, of course. This is the last slide, which is quite complex as well as many of the previous ones. Here we see how funding is developed by means of conventions and agreements. In these agreements, it is stated which will be the structures that are going to be co-funded, that are part of the social service or social system, but that can be used to provide healthcare. So in order to have these resources, we need additional funding, not so much to provide healthcare resources, because the healthcare system will always be there to cover any need that may arise. But, it would be more to share part of the financial weight of these resources. As I was saying, the resources included in the catalogue of social and health resources are generally resources that will be included in the social portfolio. And I believe that was the last slide of this part of the presentation. So John, if you agree, we can now break for coffee for a while. And then later on, we will be tackling mental health and addictions.
Thank you very much, Jose Antonio. And thank you to all of you for this interesting presentation. So indeed, we will go for a short 10 minutes break. We've been running just very slightly late. So if I can ask you all to be back at 11:05, and then we'll kick off with the session on the mental health. Thank you so much. See you soon. So it's 11:05. I believe we are all back after our short coffee break. So as it was indicated before, this part of the session we will dedicate to mental health and addictions. And after this presentation from Jose Antonio, we will switch to Slovenia for one presentation around the maturity indicated care. And then, as you were saying, we'll have a dedicated discussion. So again, just the invitation, use the chat functionality as well as we go through the presentation to keep all your questions and observations. So without further ado, I'll hand over back to Jose Antonio for his presentation.
Gracias, Andrea.
Thank you very much, Andrea. Well, the first slide shows the evolution or the development of our thinking about mental health and the different strategies that have been developed in this field. So we started quite early in Spain in 1983 with the first mental health and psychiatric care plan. Back in 1983, in the Basque country And in Spain, as well as in many other countries in the European Union, there was growing concern about these issues. And then following that, there have been different strategic developments. And at the end of all of this, we are where we are now. And we have what we call a community model. So it's a model that aims to provide care to people with a mental health care problem. And this community model has a series of characteristics and values upon which it is based. First of all, the promotion of autonomy, those with a psychiatric disorder, so autonomy, and then continuity throughout a person's lifetime, and also continuity between services. And when we talk about services, we're talking about health services and social services, accessibility as well, comprehensive care, equity or equality, personal recovery. The idea is to promote recovery as far as possible. The aim of the model is to help the person to develop as much as possible. Accountability and quality, these are the last two values or criteria. So what are the characteristics then of the mental health network of Euskadi or of the Basque country? Well, we'll talk about the network itself a little bit later on and who makes up the network. But if we look at it in broad terms, and if we look at the fact that it is actually a network, that is important. It's a network. It's a network of services which are interconnected. And the community model is the model that we try to implement throughout the network in the different structures that exist within the network. And also in the hospitals. The hospital structures are very important, the general ones and also the psychiatric hospitals. All of this is within the public system, and it's a guarantee system. We also work on addictions, trying to prevent addictions and then provide treatment. And all of this is included in the public provision of healthcare services. So in our public program, there is a specific program dedicated to addictions. That's quite unusual, especially in Spain. Usually in Spain, in other regions of Spain, addictions are treated or care is provided within private networks. But we have incorporated addictions into our public provision of services. We also have a shared information system and a shared medical history between the healthcare system and the mental health care system, which is logical as far as we are concerned. And then also much progress has been made in relation to quality management. So this is very important in all the different structures. So we have process-based management, values-based management, all of this has a very important role. It's also important to note that the network is called a network, of course, but it is made up of a series of autonomous and decentralized structures. So there is no mental health directorate. For some time, I think up until 2011, I was the last person who actually formed part of this mental health directorate because it no longer exists. And why? Well, because there is a huge degree of autonomy in the different organizations which make up the Basque Health Service. There is a tendency towards the integration of these organizations, and there's intense debate going on at the moment. It's a very interesting debate, but it is definitely intense. It's not always that peaceful. And there is also a parallel network of co-financed social and health structures. as we've seen before. We have care homes, for example, for people with severe mental illness, form a parallel network, and they are co-financed. And then once again, and you can see that we're repeating this time and time again, it's a recurring issue, and that is that there are significant territorial inequalities, so inequalities between the different provinces of the Basque Country in terms of both care and strategy. So we have a huge degree of autonomy, but there are this gives rise to different approaches, which sometimes gives rise to inequalities. So what are the structures that make up the Basque Mental Health Network? Well, we have the mental health networks. And what do they consist of? Well, psychiatric hospitals. These psychiatric hospitals in the 1980s and the 1990s, they basically made up the entire mental health service, but now they're just part of it. And in fact, their weight within the system is much lower. These psychiatric hospitals are not quite so oriented towards long-term stays, which is what the case was in the past. They have subacute units, they have different units in which patients are there for a shorter stays, for shorter times. And then we have refractory psychosis as well, because this is extremely complex. And they need a different unit there because there's very different cases. We also have mental health centers, which I think we can say are the hub of the mental health network. And they offer different programs for adults. And this is also coordinates very closely with primary healthcare. We also have a program specifically for children and adolescents. And the part of that is shared with schools. They call them educational centers, but they mean schools. Giving talks to children and therapy to children at school in order to try to prevent healthcare, to try to prevent school dropout, for example, and try to tackle specific problems. We also have our program which focuses on addictions. And we have another program which is more recent, which focuses on eating disorders, anorexia, bulimia, for example, which is something which is of growing concern amongst children. We also have aggressive compulsive disorder program, and then we have what we call the first episodes program, which aims to prevent or provide early prevention in order to avoid the chronification of psychosis. And then finally, we also have intermediate structures, which include assertive community treatment. So this intervention treatments focused on some of the more serious cases. They provide home care to people who are suffering from different mental illnesses or mental disorders, people who have very complex cases and their complex development of their pathologies. And then we have day hospitals as well. So this is the mental health work. There are 3 mental health works in the Basque Country, 1 in each of the provinces, Gipuzkoa, Vizcaya, and Álava. So we have 1 mental health network per province or historical territory, as we often call the provinces here in the Basque Country. And we also have the general hospital psychiatry services. We have these services in 5 hospitals in the Basque Country. So the largest of the hospitals have a psychiatry service, and they attend people who have been hospitalized or admitted to hospital for psychiatric problems. So there's an adult service, a child service. So there are only 3 hospitals of the 5 also provide a service to children and adolescents. They have a child and adolescent acute unit. And then finally, we have our socio-sanitary or social health resources. Now, these are resources that are shared between the health and social systems. There is one that has to do with addictions. Supervised flats is another one. Mini residents or mini residences, that's slightly different from the daycare centres. And then we have daycare centres, we have occupational workshops and employment. So this is the pathway that people with mental disorders can follow. They can use all of these different services. They're all available to them. Obviously, depending on the case, they will use some, not other, of these resources. And we always have a longitudinal approach. So it's a continuous pathway, but there's also a cross-cutting approach because all of these different services coordinate with each other. Now, I'm just going to be very brief. I'd like to very briefly mention a couple of issues. This one that we can see here, the suicide prevention strategy, is one of them. It's part of the mental health program, but it's an important social problem in the Basque Country and in many other places as well. So we have a strategy to try to prevent suicide. It was approved in 2019. It's an institutional program, a cross-cutting program in which we aim to provide a service to all the different problems that may arise using different resources, different programs, different organizations to try to provide a coordinated response to this situation. I'm sure you're worried about suicide as well in Slovenia. It's quite a widespread problem. So I just wanted to mention that. And then finally, I just wanted to mention another approach, which we call rehabilitation and recovery. This is part of the community model for mental health care, and it has to do with the rehabilitation and what professionals can do to help patients. There's a training program for professionals. We have a coaching program which focuses on the values of the community model. And its ultimate aim is to help the fight against disability. It's not so focused on symptoms or the psychopathological development of the pathology, but it's more focused on the impact of having a disability, the social stigma that people with disabilities may experience. So much more people focused, and the ultimate aim is to provide professionals with the resources that they need so that they can help their patients, their clients to have a life beyond their disability, help them search for an identity and develop a sense of self and a purpose in life. So this is an issue that I'm particularly interested in, which is probably why I've put so much information on the screen today. I've got lots of slides about this because I think it's incredibly interesting, but we don't have time to go into it in too much detail, unfortunately. So the presentation will be made available to you. So if you're interested in looking at it in more depth, then please feel free to do that. So really, that's all from me. Thank you very much. Thank you very much for your attention. And I think perhaps we can start with the question and answer or the Q&A. I don't know if anything else has to happen before that.
Thank you very much, Jose Antonio. Indeed, we will still have one presentation before we open the discussion, and it will be from our colleagues from Slovenia. So I believe, Aleš, it's over to you to give us an update on strengths and weaknesses in integrated care in Slovenia.
Lepo pozdravljeni vsi prisotni.
Hello, everyone. First of all, I'd like to say hello to everyone and thank Jon for organizing this workshop. I'd also like to thank Andrea for coordinating everything. This has been another marvelous workshop, and I really enjoyed the presentations by our Basque colleagues. So they talked about coordination and integration of health and social services, and last but not least, mental health. I think this information is extremely useful. We can draw certain parallels with Slovenia. There are certain areas where we recognize ourselves. There are certain differences. I think that the Basque country is a step ahead of us in the direction we'd like to go to. So let me begin. At the beginning, I'll talk about the challenges of integrated care on the state level. I will continue with how these challenges are faced at the local level. And in the end, I'd like to present some solutions we have been tested in Slovenia in the field of long-term care. In a way, these solutions are included in the act, in the legal act that is now being discussed in Slovenia. So, as the colleagues before me said, there is population aging both in Spain, Slovenia, and elsewhere in Europe. In the last 30 years, so between 1988 and 2019, the share of people aged 65 or more has increased drastically. It's expected to grow further 50% over the next years, which means that almost a third of all people will be older than 65 years. The slide also shows a graph, a comparison of European countries according to population, so regarding population aging. Slovenia is in the top third when it comes to that. We are above EU average in population aging rate. The population is aging very rapidly in Slovenia. This must be taken into account when preparing the country's strategic plans. The needs as they are already great, but they will continue to grow as the population ages. We need to address this challenge. And the Basque colleagues already said that there are less and less children being born and that people live increasingly long. This should not be viewed as something negative. We must provide people with quality and long-term care. So what is the situation like in Slovenia? There is no law on long-term care in Slovenia, even though there have been several proposals for a law over the last 17 years. Up until 2017, such an act was under the responsibility of the Ministry of Employment. the Ministry of Labor. Later on, this responsibility went on to the Ministry of Health, and a special directorate was founded. We believe and hope that this act will come into force soon, but it's still being discussed in Parliament. But the situation at the moment is such that rights pertaining to care are scattered among different regulations. There is no centralized access to information. There is a lot of inefficiency when it comes to the utilization of resources. The experience internationally shows that such systems should be integrated. So as I said, there is no legal act, but there are certain documents that regulate this care. One of them is a strategy for long-term care and integrated care from 2017. Then there's also the social protection resolution. It expired in 2020. Due to COVID and other issues, the new strategy hasn't been adopted yet. Also, this resolution placed great emphasis on long-term care. What are the main issues and challenges in the field of long-term care? Looking at home assistance, the services are not developed to a sufficient level and they are not accessible enough. I have certain data on home assistance from 2019. This was from the times before COVID. We don't know yet how COVID has affected this field. But talking about comparability and equal access to services, in a lot of Slovenian municipalities, in over a third of Slovenian municipalities, people could only access home assistance during the morning time. There are about over 18,000 people in Slovenia that are eligible for home assistance. Only some 300 of those people had access to these services in a sufficient amount. What is the financing like? The municipality must finance at least 50% of the costs. The rest is financed in a different way, and there are differences among municipalities. So it really depends. There are large differences as to how much the users themselves need to pay out of pocket. In some municipalities, users don't need to pay anything themselves or need to pay under 3 euros per hour. In a different Slovenian municipality, the user needs to pay over 9 euros an hour for the same service. These are certain challenges at the state level. What about the local level? Here, I'd like us to take a look at two municipalities, the municipality of Trbovlje and the municipality of Domžale. we made an assessment of how local environments are prepared for integrated care. Both diagrams are quite different, but the differences are not as big as one would assume at a first glance. We must first take a look at the first concentric circle. So the assessment 0, meaning the environment is not prepared, we're not suitable for integrated care, and 12 being the maximum number. In Domžale, the focus is on prevention. This can help people have access to different services before problems emerge. This was rated by 4. Other fields were rated 3 or less. This means that the environment is not really suitable for integrated care at the moment. What were the main challenges that people mentioned? You can see them stated below. But I'd like to focus at some that are more local than related to the state level. Most people said that there is no coordinator, a coordinator that would work with various stakeholders. Another issue was a lack of education for elderly people, especially ICT education. Stakeholders in both environments have pointed out that the elderly need to be better informed. They need either a physical point where they could go, a website, or brochures. There needs to be better awareness among the elderly. And then there's also e-care, which is currently underused, even though it has proven to be a very useful tool. We find that e-care is not very well known in Slovenia, so people don't even know that they can use it. So these were the key challenges that people have pointed out. People in local environments wish that a long-term act would be adopted. This means we all wish a systemic regulation of long-term care. That would make it easier to govern care at the municipality level. Now let me continue with presenting to you how long-term care is being planned at the moment. When drafting the Long-Term Act, there were 3 pilot projects implemented in Slovenia. One environment was semi-rural, one was urban, and one rural. There we tested various mechanisms. I'd like to present these mechanisms to you and like to focus on a greater integration of services. With this aim, single entry points were set up in these environments. In these entry points, various assessors were employed. Those assessors included a nurse, a social worker, an occupational therapist, and a physical therapist. What is the main function of an entry point? This makes it easier and faster for a user to access services. The user submits an application to the entry point either in a paper form or electronically. Once the application arrives at the entry point, the process begins. And this is a single uniform process from the beginning to the end of care. So the first step is that assessors make an assessment of the needs. We are using an instrument or a tool that we adopted from Germany. This is a single tool. The entry point has one important function. It informs the user about the activities that are offered. It also informs the user about the Slovenian legislature. That means that even if the user is not eligible for care, the user is empowered and helped to submit other applications so that they can find the help they need. Another important element is the LTC coordinator. This work can be performed by either a social worker or a nurse with the necessary education. The coordinator coordinates the entry point, the care team, and volunteers. So one of the tasks is the coordination of all stakeholders, and another very interesting, very important task is to create a personalized plan for the user. Here, it's very important to know the entire personal history of the user. This is why the coordinator should take a look at the bigger picture, not only social or health issues. Part of the personalized plan is also an implementation plan. And this plan is then based on all the information gathered about the user and tells what the care process will look like. So what we are trying to do is take into account the entire life story, so to say, of an individual and help them in the best way possible. Now let me move on. Once we have the implementation plan, the user is beginning to make use of various services. The user then has access to a care team. There's a unit for everyday chores and a team for independence. So it may include nurses, healthcare technicians, and social carers. So this is the basic daily tasks unit. Then there is the unit for maintaining independence, consisting of various carers, including occupational therapists, physical therapists, social workers, and kinesiologists. Our experience has shown that this can help improve the quality of life of users greatly. One of the main challenges is having enough suitable staff. This will continue to be a challenge in Slovenia, even once we have the required legislature. We don't have enough people in these professions. To conclude, I'd just like to tell you what the cooperation among stakeholders looked like during our pilot project. So from the beginning, the stakeholders were part of a consortium. They were part of a partnership. There was a project council that met from time to time, and this facilitated the cooperation among stakeholders. This shows, as was also said in previous presentations, that cooperation is extremely important. That's all from me. That's what the situation is like in Slovenia.
Thank you very much, Aleš, for this very informative presentation. I think it was really useful to compare and contrast the stories. And as I mentioned in the chat, for me, it was particularly that fact that, compared to the Basque country, you are still working on your law or kind of like further governance model. So I think it's really interesting to see, as a, considering that it was mentioned in a couple of presentations that political commitment and that kind of like governance structure is absolutely crucial for that coordination of health and social care services. So I believe there is a lot of scope for kind of like further exchange in terms of, preparation of that law and further governance model. So I'll now open the floor for a discussion. I do have a couple of questions from my side, but first I would like to obviously give the floor to our colleagues from Slovenia. So I'll just pick up on the first question, which was posed by Matija. Matija, feel free to step in if you need any additional information or additional question. And it was about education and training. So we heard from Lucia about those multidisciplinary teams and multidisciplinary profiles that are required for those teams. So there was a question, how do you provide trainings and education to these different roles, considering that they might come from different sectors like health and social care. So yeah, it's open for anyone to pick up on this question. I assume it's still being translated.
Entiendo que cualquiera entre José Antonio, Amaya.
I think maybe José Antonio, Amaya, or Lucia should be answering that question. Maybe José Antonio? I think Amaya's talking on the telephone. Okay, so the profiles. Well, I think in this sort of situation, this is when we can see the diverse types of approaches that we can adopt in different areas. So the profiles are primary care profiles mainly. Now that profile will be maybe either a physician or a member of the nursing staff. This is the basic two figures. And the idea is not perhaps to specialize them too much or to give them too much specialist training in this particular area, but to provide them with basic training so that they can perceive the needs much better when someone comes to their clinic. This is for the health side of things. And on the social side of things, the profile would be a social worker. And then with the team made up by the physician, nursing staff, and social worker, once they have exchanged information between all three of these figures, there's been an information exchange, they get a much better idea of what needs need to be met. And then once that's done, other profiles may come in to the picture. They may be brought in, like they do perhaps, I don't know, in Slovenia, the physiotherapist, for example, like you mentioned. Or other profiles may be brought in. But in order to carry out the diagnosis and to conceptualize what is required and what this person needs and what the approach will be, what the intervention will be, we generally use these three profiles: physician, nurse, and social worker. Unless there are very specific problems. I mean, if we're talking about dependency, there could be very diverse range of profiles, for example. There could be the home care provider, the people who provide help with the daily activities or the basic activities of daily living, physiotherapists, as you indeed mentioned, other issues, if they are involved, may require other profiles, psychologists, for example. I mean, there's a huge range of different possibilities, but of course, this range will depend on the needs that we have detected. I don't know if this has answered your question, but this is what we're doing at the moment.
Thank you very much. Mattia, are there any comments from your side or additional question in relation to that?
Yes, thank you very much for this comprehensive answer. As I understood, the focus is on primary education, and then to a smaller extent, further education and training on these topics. But as you say, the focus is on cooperation among various profiles who continue their education in their primary disciplines. That was my question, and you answered it. Thank you very much.
Thank you, Mattia. I see Alish with the raised hand. So Alish, over to you.
Yes, I forgot to mention something. While we wait to have a law on integrated care, Slovenian municipalities already work actively on regulating this field. There have been several workshops and discussions on what we can do on the local level. Particularly in Domžale, they started solving this problem in a very comprehensive manner. In 2019, there was a comprehensive assessment of needs in the local environment. It related to the elderly. Based on this, they also published a book that prepared strategies on the local level. So they have already started. They have already started working intensely to look for good solutions. Now I'd like to ask my Basque colleagues a question about socio-sanitary coordinator. So there are about 70 such coordinators, and you expect to have more. Is there a way to connect these coordinators? Is there a level above these coordinators that ensures that they work together?
Itziar, would you like to respond? You can, but we're talking about 70 reference figures. They're not necessarily coordinators. There are 6 coordinators in each province, but there are 70 reference figures. That's what we call them. So these 70 reference figures, you asked 2 questions, right? What's the role? What do they actually do? Well, they don't just provide care. The stakeholders in the social and well, there are thousands of stakeholders in the social and health systems: physicians, nurses, social workers, people who work at local councils. These are the stakeholders who acquire, we hope they're going to acquire these competencies and to acquire this culture of coordination. But then within each organization, we have reference figures. And these are people who are empowered. They are empowered, they have been identified, and they serve as a bridge between different professionals and between different organizations. They serve as liaisons in order to provide services, in order to facilitate the work carried out by organizations at a meso level. So that's what they do. They're there as liaisons. They coordinate. They're people who have been identified as key figures. So they're intermediaries, if you like. Now, you asked whether there was a higher level, no, above these reference figures that guarantees their coordination. Well, obviously, we haven't mentioned every single structure that exists because there wasn't enough time, but there is an important structure that we didn't mention, and those were the social and health commissions, which are regional in nature. So they're not regional, they're sub-provincial, if you like. And there is a commission, a social and healthcare commission in each sub-provincial region. And they are there to guarantee good coordination between the reference figures. And it's at that level, in these commissions, that the communication takes place between the reference figures, and the sub-provincial plan is developed for all the different reference figures in that sub-provincial area. Priorities are established and plans are made as well by these commissions. And there's another thing that needs to be taken into account, and I didn't say it beforehand, but it's very important in relation to these reference figures. As I said, service provision is different in the health system and in comparison with the social system. So it's a different service provision. Now, even though there are social workers in the health system, the social workers who are actually in the health system cannot provide services such as help for dementia, home services, referral to a nursing home. They can't do that. All of these services are provided by the social services, and the health service doesn't have the capacity to provide these services, even though there are social workers working in the health service, and vice versa. The social system doesn't have the capacity to, I don't know, kickstart a certain provision of services if they're health services, which is why coordination is so important. Coordination between professionals, this is so important. And the reference figures play a key role in that because they're sort of one level higher, if you like. They serve as bridges between the two systems and local councils, and they tell everybody what the needs are. And then one step above them, we have the provincial level, we have the provincial councils, which Amaya was talking about, which see these needs from a more holistic and a broader perspective. But we have all of these different levels. We have the reference figures, the commission, the council, all of these levels are connected.
Sounds really impressive. Aleš or the team, any further reflections or questions with, in this respect?
Ne, najlepša hvala, je bilo res tako. No, zdaj pa,
No, thank you. I can understand it well now what the role is. Thank you for that answer.
Great.
I also saw there was a question for us. So the exact name of the tool we're using, it's an NBA tool, including 8 fields. In Slovenia, we will use all of the 8 areas. The important thing with this tool is that it doesn't allow a lot of space for differences. So that means that the assessments are uniform. This has improved to be very good and useful for us. It's an NBA scale adopted and adapted from Germany. In this aspect, I don't know if you saw it in the presentation, various profile at the entry point. So the social worker, a nurse, a physical therapist, This is also important in Slovenia. We also have to organize training. There are going to be various entry points in Slovenia, and the assessment process needs to be the same. We need to make sure that we have a uniform process and assessment tools. The tool that we use must provide a framework so that there are not a lot of deviations when applied at the local level. Maybe Mateja has something more to add. Yes, just briefly. Thank you, Aleš. I just wanted to post some useful links into the chat box, but I have a technical issue. If anyone is interested and would like to know more about the tool, please contact me. Based on the pilot project that we have implemented, there's also a website regarding that. So if you're interested, please contact me. If there's time, I'd like to ask another question, but no problem if there's no time. Is there?
Yeah, go ahead for more questions. One more. Yeah.
Thank you, Andrea. In the Basque country, you mentioned that there have been several pilot projects. What I'd like to know is how you implemented these solutions. What was the transfer to the system level like? What were the organizational and timeline aspects? What was your experience in this field?
José Antonio.
Bien.
Antonio, do you want to answer? Yes. Well, people say that you learn from your mistakes, mainly. So if that's true, then we know a lot. And I think that our greatest success, even though it was a failure, was to try to implement a tool, Interreg, it was called, Interreg. This is a Canadian tool for social and healthcare diagnosis. We tried to implement it throughout the entire Basque Country. It was a tool that was going to enable the interoperability of the different systems. It was going to carry out a shared and common diagnosis between the two systems, the healthcare system and the social system. And It was going to generate individualized health plans based on an interview that would last between 20 and 30 minutes, an interview with the patient in question. So it was a really good tool, and it has been implemented successfully in other countries, and in fact in other areas here in the Basque Country as well. It enables a certain degree of stratification, but when we carried out this pilot project, which was carried out, I think it was in 2013, 2014, around there. Well, in that pilot project, we saw that it was great, the tool was great, when it was implemented with a very prescriptive approach, telling the teams what they had to do. But apart from that, it was not a success. Itziar was involved in the implementation of this pilot project, and Lucia, you worked there as well. We worked really hard to try to implement the tool, but we had to give up in the end. We had to bow to the evidence because despite the fact that it was a very good tool, the local ecosystems that we had here and the local culture had a lot of force, a very, very strong here, and it simply wasn't compatible. And so we abandoned the attempt in the end. And I'm telling you this, I'm telling you the story of a failure just to, give you an example, and I'm telling you it because we learned from it. We learned from this failure. And what did we learn? Well, we learned that when you're actually going to implement a pilot project, you can't be prescriptive in the way that you act. You have to look and take into account the local ecosystems and the local care systems and how they work. And you also need to be respectful of the local relationships and the way those relationships work. Now, there's another project that Lucia mentioned earlier, and this is the shared time agenda. So the idea is to reserve a space in professionals' diaries and their agendas for this interrelationship, for this coordination, so that there's a time reserved for that. We did that in a small sub-provincial area called Goyeri. It's in the province of Guipúzcoa. So we tried it out there. And I don't know if we can call it luck, but I think we were lucky, or we got it right in the sense that we gave it enough time and it was successful. But we took our time doing it. I mean, it took 9 months. We implemented it over the course of 9 months. So we gave the teams time to understand it. And in fact, that pilot project, it was successful. And so what's the tactic now to implement the rest of it? Well, first of all, there are 2 things that we've learned. That not everything works, not all pilot projects are going to work. It's an important thing to learn. And then the social and healthcare system culture needs time to adapt to changes. It needs time if you're going to implement something. So you need to take your time. People need to get to know each other. People need to understand what's happening. So implementation doesn't happen overnight. And I think that's really the answer. Not to be in a rush, that would be my advice, and just move forward steadily and slowly.
Por añadir algo de información, el
To
pilotaje.
add some additional information, I would say that, well, you were asking how we implemented the tool. Well, at first it was designed for a short range pilot study, 70 licenses, and we ended up having endless licenses and more than 700 people involved. But there were a number of difficulties there, which made it impossible to use the tool in the teams, mainly a healthcare bias on the social side, because they would say that the tool had data they couldn't access. Therefore, it was like a bottleneck for them. Jose Antonio was right. One of the things we've learned at the methodological level is that we need to be adaptive. We need to adapt ourselves to the different rhythms and to the needs of each local context, which makes pilots very complex because each municipality may have very different needs from others. But if we adapt ourselves, we can move forward. And in the pilot study of the tool in the healthcare system, the reference people were very empowered, very much empowered. And on the social side, we lacked that degree of development, but we are trying to cover for that in this new stage with new pilot studies.
Thank you very much. Thank you so much for both interventions. I think we are definitely coming to an end. Apologies for running a bit later. But I think that the best message I've taken at the end for the summary is what Jose Antonio mentioned, learn from the failures. And I think that's really very much appreciated that you actually share not only the successes, but really, as you said, like learning from the failures, and we really appreciate it. And definitely it's been one of the ethos within the Scirocco Exchange project. Let's share both what worked, but also what didn't work, so that the others don't repeat the same mistakes and move on much faster in their journey towards integrated care. So thank you so much to the whole Basque team, to Jon for organizing these very informative sessions for us. Thank you also for all Slovenian colleagues for their kind of like inputs to the sessions. As we were saying, it's been recorded actually in all 3 languages. So we will have very informative resources after the workshop. We will also share information about the tool which Mateja has mentioned. So Jon, I will definitely share it with you so that the colleagues from the Basque country have the access to information. And you will be kind of like in touch with more kind of like formal steps afterwards. I would like to encourage Slovenian teams to, go through again the presentations, the recording, and see if there is anything else that you wish to potentially, pursue further. So we would be, I'm sure that we're very happy to do any follow-up as needed. So thank you so much to everyone. It was really a pleasure to spending this morning with you, and looking forward to the next steps in the both regions. Enjoy the rest of your day. Bye-bye.